Hello again. I'd like to welcome everyone to another video from behind the siren. In this video, I'm providing a condensed overview of what is involved in running a 911 call. This video will fall massively short on the specifics that these calls have, but I want to expose just a general sense of what to expect. Later videos, I will cover the specifics at a much greater detail. The job of a first responder, specifically a paramedic, comes with caveats. These caveats are nothing new and seem like they are a default working as a paramedic. Examples of these caveats include you will encounter scenes with dead bodies, or sometimes no matter how hard you try, some people just cannot be saved, or don't take your work home with you. In my first year, my mind seemed to be blown away at least every other shift. That's not out of the ordinary because every call seemed to have something that I had never encountered before. A deep laceration in an arm caused by a jagged piece of metal after a vehicle accident. The blue face of a person who was desperately trying to gulp down air but couldn't because of their asthma. A small red bump caused by a bee sting that would soon develop into full-blown anaphylactic shock. These are just a few of the hundreds of different scenarios that a first responder would encounter in the few months of their career. Let me back up a moment and explain some EMS jargon. An EMT, or emergency medical technician, is part of a two-man team. The other part of that team would be a paramedic. This two-man team is what makes up an ambulance crew. The paramedic is technically in charge. With a few years of extra schooling, the paramedic is an extension of the medical director. The medical director is a physician who writes the protocols for that EMS system. The protocols are a general overview of how to respond to emergencies that are broken up into medical and trauma. Asthma would be a medical emergency, and a car wreck would be a traumatic emergency. The term paramedic actually comes from Greek and Latin. Greek para means besides, and Latin medicus means physician, besides a physician. So we are an extension of the physician. As part of an extension of the medical director, a paramedic is tasked to do many objectives. I'll expose a quick rundown of a usual emergency call. First, before we can treat a patient, we must first get to that patient. A two-man elite team made up of an EMT and a paramedic are dispatched. The EMT drives and the medic is in the passenger seat. As we start to move, we relay to dispatch we are responding. On go the lights, then the sirens. Our goal is to make it to the scene as quickly but as safely as possible. Safety trumps speed. Sometimes, en route, we must decide to drive backwards down a one-way, drive down the median, or drive south in the northbound lane. We can't run red lights, wink wink, or stop signs. We must drive with due regard. But every so often, with no traffic, we redline that thing. When arriving on scene, we let dispatch know. The hardest pill to swallow as a medic was realizing I would not be driving emergency anymore. Oh well. Upon scene arrival, we ran down a list of protocols. First, is the scene safe? That has a lot of meanings, but usually a safe scene for a medical call would be, is the patient non-combative, and are any family members or the general public on scene going to interfere? In trauma calls, for example, a vehicle accident, we look at the vehicle's condition. Are we able to access the patient safely? Is there any leaking gas or fluids that may cause a safety concern, etc.? Once the scene is safe, then the gears start to turn. Making initial patient contact is usually quick. There are three situations. Is the patient emergent, urgent, or non-urgent? Emergent patients need hospital care within 15 minutes. These cases are life-threatening. Examples include gunshots, stabs, electrocutions, cardiac arrest, heart attacks. The next is urgent. Patients need care no later than 60 minutes of initial contact. These cases are usually non-life-threatening but need care within the hour. The last is non-urgent. These require care but at no set time. Patients may or may not need care at a facility. Once a medic has placed the patient into the correct category, he will provide the correct care. Most patients fall into the second and third category. After our initial patient assessment, in steps the EMT. As a medic, we hopefully have an EMT partner that we can trust. If so, we turn any basic life support functions to them. Airway, breathing, circulation. These come first. Then usually getting a first set of vital signs, as well as applying the cardiac monitor and oxygen if applicable. And finally, venipuncture. Introducing a needle into a patient's vein and placing a plastic catheter within the vein. This is all done by the EMT within the first 5 minutes, hopefully. While the EMT is doing this, they will also provide a follow-up assessment to our initial assessment. Sometimes patients can present as non-urgent, but become urgent quickly, so the EMT will provide us that information. If the patient does not change status, the paramedic's main job is to utilize his mouth. Finding out pertinent and non-pertinent information is crucial in how we treat the patient and where we need to take the patient. For a medical assessment, I used the acronym OPQRST. Chest pain, for example. O, onset. Did the pain start suddenly or gradual? And what were you doing when the pain started? P, provocation. What makes your pain better or worse? Quality. Try describing your pain to me. What does it feel like? R, radiation. Point to where your pain is the greatest and does it move from that point? S, severity. On a scale of 1 to 10, give me a number of your pain. 1 being the lowest, 10 being the worst. And T, time. When did your pain start? How long ago? As the EMT is doing his work, I will be assessing the patient using OPQRST. Also, if possible, I will be finding out the patient's medical history. By using sample as a mnemonic device, I gather a patient's medical history during a secondary assessment. It stands for S, signs and symptoms, which may include vital signs. A, allergies to medications, food, insects, bites, or other substances. M, medications, including prescription, over-the-counter, or illegal drugs, and for what condition the patient is taking them for. P, past medical history, including any problems the patient has had, and the name of their primary care physician. L is last oral intake, such as meal or menstrual cycle. And E is events leading up to the injury or illness, such as what prompted the call for emergency services. I will gather valuable knowledge as well as how to treat my patient going forward, what patients I needed to give and what I can't give, what hospital does this patient need to be transported to, does this patient need more diagnostic evaluations such as a 12-lead EKG. Hopefully the patient can give us this information. Sometimes the patient is unable to, and then we must provide the right family member to provide us with that. Sometimes there is no one around to give us any information. After our first assessment, vital signs, IV access, cardiac monitor, and oxygen, and after the medic has performed OPQRST and sample, we should have the right facility and the right ongoing treatment noted. Then we are off. During transport, the EMT is tasked with getting everyone on the ambulance to the correct facility in a safe manner. Most transports are non-emergent, so lights and sirens are not utilized. In the back, where the medic rides, we routinely sit in the jump seat, which is directly behind the head of the patient. Even while buckled in, the setup allows us to monitor the patient. We can also monitor anything applied to the patient, i.e. cardiac monitor and oxygen. After being situated, the medic would then call over the radio to whichever hospital we were heading to and ask them if they were ready to hear a report. After being acknowledged, The medic would then make a clear and concise report to the facility. This report would involve the patient's demographic, the patient's medical history, what type of patient we had, the treatments to that patient, and the outcomes of those treatments. Finally, we would provide an ETA to that facility. Hopefully, the receiving facility can make out what we had said. To be honest, the radio report for me and for many other new medics was the most terrifying of all aspects. Your report needed to provide all the necessary information in a short, concise statement. There should be no ums or well. It took a few months and many mess-ups for me to finally be somewhat comfortable doing those. After that, we would have time to make small talk with the patient, if they were willing. I would usually talk about anything unrelated to them being in an ambulance, sports, favorite hobby, etc. One trick I used would be if they were wearing a cap of their favorite sports team, I'd give them a hard time about it, and we usually would be laughing while we pulled up in the hospital bay. The next move is that we would remove the patient from the ambulance on the stretcher and into the receiving facility, usually the ER at a hospital. We would be greeted by the charge nurse and moved to a room. We'd then slide the patient from our stretcher to the hospital bed. The EMT at that time would remove the stretcher and take it back to the ambulance. The EMT would change the linens and clean and sanitize our workstation as needed. Sometimes a light cleaning would suffice. Occasionally, the cleanup would not be so light. As the EMT was doing that, the medic was providing an overview of the situation, the who, what, when, where, and why, along with the past medical history and any treatment provided to the patient. The medic would then write his patient care report and get any signatures needed. After a clean truck and signed report, we would update dispatch if we were clear from the call and available for the next. Then we would make our way back to the designated territory. So there it is, a general glimpse into what an EMT and paramedic do while treating a patient. As I said earlier, I'm going to dive deep into the specifics of a lot more. Basically anything I can think of that it was involved in my line of work. And I'd ask for you guys to give me ideas that you would like me to create content of. Thanks for watching, and give me some love if you enjoyed this. And as always, stay blessed.